Today, I'm going to go through a comprehensive viva-style chat about a particular topic. Today's topic will be obstetrics. I'm going to try and pack this case with as much useful information as possible. So in this scenario, let's take a 30-year-old female, G3P2 at 18 weeks for emergency lap appendicectomy. She's had 2 previous seizures under a spinal anesthetic, but no known allergies and no past medical history. She's very concerned about the risk to her baby. So in answering this question, I'd start by saying this is obviously a very concerning situation, and I'd attend to the patient. After doing a full anesthetic history, I'd also ask about any particular concerns. These particular concerns are often teratogenicity of doing the surgery of the anesthetic and the risk of miscarriage. So fortunately, I can offer information about that. So teratogenicity is really dependent on the time for organ development, and after the first trimester, most organogenesis is complete. Also, that large studies and populations of people having surgery have shown no increased rate of teratogenicity after surgery compared with controls. The risk of miscarriage is increased, but also that it is probably best to take care of the patient having this emergency pathology, because that also has a rate of miscarriage, and there really is limited options in an emergency situation such as this. So in that situation, I'm expecting what the examiner would want me to talk about, teratogenicity and miscarriage, and I'm offering that information so I can quickly go through the complete story of counseling this patient. If they're asked, what about nitrous? Would you be concerned about using nitrous? I may give an answer such that, for this case, I don't think nitrous is necessary. Nitrous inhibits methionine synthetase and has evidence that it can be teratogenic in animal studies, so I'd avoid it. If I was forced to use it in another context, I might use limited doses, less than 50%, but in this case, I would not need to use it. If I was asked about the need to use any non-steroidals, again, I'd say I'd probably avoid it in this case. There's early fetal loss in the first trimester, as well as premature closure of the ductus arteriosus in the 3rd trimester. So you'd be able to provide analgesia with other medications in this circumstance without exposing the patient to NSAIDs. If I was asked, when should you do this operation? I'd say, look, this is an urgent operation, and fortunately in the 2nd trimester, this is probably the ideal time if you were to do an operation during pregnancy. And this operation is unlikely to be delayed. I'll do this immediately for the safety of the mother. If I was asked, when should elective surgery occur post-op? Essentially, I want to wait until the maternal physiology is back to somewhere normal, and this is roughly around 6 weeks. So I'd offer that, allowing 6 weeks to allow resolution of the physiological changes. Now, for this, getting back to this case, if you were asked to do the anesthetic for this case, what were the things you want to consider for the anesthetic? And so the way I'd answer this is I'd try to take out the points of difference. I'd try to mention the points of difference for this case versus every other case. So I'll do a standard anesthetic as I would for any other laparoscopic appendicectomy. So I'd do a rapid sequence induction, but I'd be making particular attention to minimize any teratogenic drugs. So I'd use my normal combination of agents, which are safe in this patient. I'd consider if this was a gravid uterus. Now I'd usually do aorta. So I'd usually do a right wedge to avoid aortocaval compression, and usually this is after 20 weeks. But if the patient looked like they had a gravid uterus at 18 weeks, I would also consider. I'd do this in this circumstance as well. If this was a case that could be done under regional, I would consider that, but this is not that case. But I also think of DVT prophylaxis in this situation as well. While there isn't an increased risk for necessarily an increased aspiration risk if the patient has no symptoms, because it's a lap appendicectomy, I would treat this as an aspiration risk in most circumstances. So the surgery is uneventful and the patient recovers normally. You're called to assess her. So now she's in the labor ward. This is now, say, 19 weeks later. So let's say she's 39 weeks and they're inducing her for labor, and she's not progressing well and may need an epidural. So again, she's 30 years old, G3P2, 2 previous seizures under spinal, no allergies previously, and nil past medical history or that you know of. So what do you want to know for this patient? So essentially when I get this question, I'm thinking about my anesthetic assessment as well as my epidural assessment. So I'd offer that, look, I'd do a full anesthetic assessment, and aside from my usual anesthetic assessment, I'd really want to know about each previous cesarean, and exactly what the anaesthetic was like and why they're proceeding with this plan. Now, I've made this situation a bit artificial, that after 2 previous Caesars, you'd probably want to go ahead with another cesarean if that was the case. But just for the interest of this exercise, we're going through placing epidural for a normal delivery here. So the most important things is I want to know about each of the previous anaesthetics and what occurred. I want to ask a medical history about any preeclampsia symptoms, gestational diabetes, any problems with coagulopathies or any back issues as well. On investigation, I particularly want to know about a group and hold and if there's any presence of antibodies, because that could delay any blood transfusion or cross-matching. I want to know HB and platelets. I also am very interested to know about any ultrasound scans, knowing that if this patient had placenta previa with 2 previous Caesars, there's a marked increase in the risk of a placental adhesive disorder. And so, the data would show that roughly, if you have placenta previa after 1 previous Caesar, there's a risk of 11% risk of having an adhesive disorder of placenta accreta. After 2, it's 40%, 3, 61%, and 4, 67%. So quite remarkable risk of accreta at this point. So at that point, the junior obs resident mentions that her blood pressures have been quite high. What else do you want to know? So essentially, I'm now concerned that this is preeclampsia. So I'd want to know that. I'd want to know what the trend of the blood pressures are. So is this just a spot high blood pressure, or has it been consistently high? And if it is, I'm worried about preeclampsia. And then I'm noting that the definition of preeclampsia includes hypertension after 20 weeks of gestation, and obviously resolving after 3 months postpartum, of blood pressures greater than 140 systolic or 90 diastolic, and one of these other symptoms, which is proteinuria or renal insufficiency, liver disease, neurological problems, hematological problems, and fetal growth restriction. And so then, let's say this is preeclampsia. The examiner asks you, what do you want to suggest about a preeclampsia management? What are her priorities? And again, this is a time where I like to list the priorities in sequence. So I don't want to go into the detail first of all, I'll offer that later. So my critical priorities are to maintain good blood pressure control, seizure prophylaxis, check coagulation status, cautious fluid administration, and also timely delivery of the fetus and checking for fetal status as well. If I was to then be asked about more detail about the blood pressure management, I would offer all the different solutions. So I would commence with whatever the local guidelines are: methyl-dopa, labetalol, nifedipine, hydralazine, and escalate these agents as required. For seizure prophylaxis, if this was severe preeclampsia, there may be an indication for a magnesium, a 4-gram load followed by 1 gram per hour for 24 hours, measuring for any side effects and treating them as required. And this is because in severe preeclampsia, you have a number needed to treat of 50 and giving magnesium. Again, if it's mild, it might be more contentious. And again, I would discuss with the obstetric team. In terms of blood pressure management, you may get asked, how do you want to lower this blood pressure? And obviously the answer is cautiously. In this situation, the fact that you have tricky vasculature and dropping the blood pressure too quickly might compromise organ perfusion. So I'd say something like, I'd aim, if it was severe above 160, 170, I'd aim for 140, 150, dropping the blood pressure 10 to 20 millimeters mercury every 10 to 20 minutes, and not doing it too dramatically. So let's move on with this. So let's say you're worried about magnesium toxicity in this patient. You may be asked, what's the treatment for this? And the treatment would be giving calcium chloride, stopping the infusion, giving calcium chloride 10% to treat the hypermagnesemia. As this viva goes, you're on that night, and an epidural is requested after you assess this patient. You attend the patient. What do you want to know? So in this situation, I'd go through a full consent of the patient. I'd also want to check the platelets and any coagulopathy, considering that she has signs of preeclampsia. And then I'd examine the patient to ensure the back is okay and go through the full consent process. Let's say the examiner offers that the platelets are 80. What do you do? I'd first ask for that the coags are normal, and also ask for a trend. My cutoff is to be comfortable with the appropriate consent to insert an epidural above platelets of 75, as this is not shown to have significantly increased risk as long as the coags are normal. So sometimes the examiner might want to see where your cutoff is. So they might explore the fact that how about the platelets are 74 or 73. And I think most people's advice for this would be to just stick to your mark and offer an epidural up to a certain point and not below. And that would be a common thing. So not to be led down a path where you're just saying it's okay to go one platelet count lower until you're at 50 or something like that. So as this case goes on, so you're happy to insert that epidural at above 75, which you do so. What do you say to your patient for the consent? And what is required for this consent? So I might just go through my normal consent process, saying that this consent should be informed, that I provide information about the procedure, the risks, benefits, and alternatives, and make sure that it's voluntary and the patient has capacity. And there's always the argument that during labor itself, that this capacity may be difficult. What happens if the patient tells you, I don't want to hear the consent, I just put the thing in? There's an ANZCA document on this, so the professional guidelines about the consent process, and it would go on to say something along the lines of, you should then check that this was the case, that the patient definitely didn't want to hear it. So again, check another time and then document this. Because it is a very safe procedure done in multiple different environments with a very good safety profile, I would then proceed with this for pain relief. Good. So now, let's say the epidural is working well. Again, we're just progressing through all the possible bad things that could happen in this very unfortunate patient's journey. So the epidural is working well. It's now, say, 2 a.m. and you're called for an urgent Caesar in this patient. What do you do? So I immediately attend to the patient and get theatre ready. I ask the surgeon, what's the indication for the Caesar, and is there time for an epidural top-up, and is the epidural working? So after finding out that information, I then use a 2% solution with adrenaline, with 1 in 200,000 adrenaline, 2% lignocaine with 1 in 200,000 adrenaline, and 2 mils of bicarbonate solution for fast onset, and I start titrating 5 mils at a time while the patient is monitored, knowing that this is probably the fastest way to get to a good block. I check the block, check for sensation and for motor block, and then proceed when that's appropriate. Now the examiner then asks, she starts feeling a sensation as they've gone through the first few layers. What do you do? So I first say that this is a very critical situation, that the patient could be feeling pain. I ask the surgeons to stop and clarify from the patient what she's feeling, knowing that this might just be pressure sensations and not pain. But if she is feeling sharp, painful sensations and she's in distress, the first thing I do after asking the surgeon to stop is to offer a general anesthetic, knowing that there's a long way to go with this operation, and intravenous agents would probably be inappropriate. This might change at the end of the surgery. If you're closing up the superficial layers, I might say something similar. I would ask the surgeon to stop. I would offer the patient a general anesthetic, but also note that there's not much further to go, and that we can give her lots of medications to help her through the next process. And this could include everything from further opioids, alfentanil, fentanyl, remifentanil, some ketamine, even some midazolam in small doses, making sure that we're not obtunding the airway reflexes, as well as local anesthetic in the wound, as well as giving nitrous via the anesthetic circuit. So there's a lot of things we could do at the end of the case, but not at the start of the case. There was a case in Australia that I think a lot of us Australian trainees have heard about, and this case was the fact that there was a patient who felt pain, and on the analysis or review of this case, she was never offered a general anesthetic, so there was a huge payout for that. And so it's very important that we offer a general anesthetic if the patient's feeling sensations that are uncomfortable. So it is apparent that she needs a general anesthetic. How do you convert, and what do you do? So again, I'll do a rapid sequence induction for this patient, getting my usual assistance, monitoring equipment and drugs. My anesthetic for this, my priorities are, because of preeclampsia, to really avoid a hypertensive response that could trigger an intracranial hemorrhage if their patient has uncontrolled hypertension at this stage. So I do an induction with 150 milligrams of propofol, assuming this patient is normal weight, 100 milligrams of sux, and 1,000 of alfentanil. I use a video laryngoscope, ensuring the patient is appropriately preoxygenated and positioned while I'm setting up as well. I would probably run a mixture of nitrous and volatile to minimize the uterus effects of volatile and to improve tone. And if there's any issues with this, I'd run Tiva propofol for any floppy uterus or lack of tone. As this viva goes on, let's say after delivery of the baby, you are told that the patient becomes hypotensive due to increased blood loss. At this point, this is an evolving situation. I'd say it is quite concerning. First of all, I'd scan the surgeon, the patient, and the monitors, and talk to the surgeon about what level of blood loss and what they think the cause is. I would try to increase the fluids, and may ask for assistance depending on what my blood pressures are and how tachycardic the patient is, getting an arterial line and another large bore cannula in situ. Now, the way I tackle any kind of blood loss case is the 4 T's. So tissue, tone, thrombin, and trauma. And I'm going to go through these in sequence. So once I've listed my potential problems, I then go through these in detail. So for tone, I would escalate my medical management after giving oxytocin. I'd then follow with ergometrin and then carbopros, assuming no contraindications. I also ask the surgeon to consider manual rubbing of the uterus, a Bakri balloon, a Beal-inch suture, and then further interventions such as arterial ligation, uterine artery ligation, and looking towards a hysterectomy. For tissue, this patient was at risk of an adhesive disorder, so I'd firmly ask the surgeons to clarify whether there's any problems with an adhesive placenta or any other tissue. So that's tone and tissue. I think about trauma, so again ask the surgeons if there's any problems with bleeding trauma. And finally, thrombin. So I'd want to know what the coagulation status is. I'd run off a ROTEM as well as coags, and then I'd treat as per the ROTEM findings, whether this is a fibrinolysis issue, a fibrinogen issue, a coagulation factor issue, or platelets, and then liaise with hematology. If there's a dramatic rate of loss of blood, or I was looking at giving multiple units of transfusion, I'd activate the massive transfusion protocol. I'd probably mobilize a hematologist for advice, blood bank, and cell save and perfusionist, and knowing that this could get pretty hairy. And I'd also ask for further assistance from any colleagues. So the viva goes on to say, she's losing blood rapidly due to an adherent placenta. What do you do? So this is essentially a crisis. I would try to mobilize as much resources that I could at 2 a.m. And this could include ICU staff, emergency staff, or other doctors, critically trained doctors in the hospital. So my priorities are really these things. I want to replace blood and activate the massive transfusion protocol. I want to maintain the cardiovascular stability of the patient, and I want to facilitate good, fast surgical intervention. So what I've done here is I've tried to highlight the fact that this is a crisis, and then I want to highlight my multiple or parallel management threads. So those threads were replacing volume, maintaining hemodynamic stability, and sorting out the surgical issue. If the surgeon, for example, if the surgeon wasn't comfortable doing a hysterectomy, we'd have to mobilize other surgical team members to assist with that. Resuscitating the patient with blood, it's its own kettle of fish, really. So having the level 1, multiple people running to a blood bank, checking blood, giving factors, checking the ROTEM, that's its whole other topic. That's a whole other topic and a whole other system that I could have one anaesthetist really running, and I'd probably take role as leader and also manage the hemodynamics depending on how many staff I had. Good, so then the viva goes on, the patient stabilizes, hysterectomy is successful. After 15 units of red blood cells, FFP and cryo, you decide to take the patient to ICU intubated. What do you need to do? And so this is essentially part of the professional document. So I'd firstly say that there is a professional document on the intra-hospital transfer, especially to ICU, and I'd consider monitoring, having exactly the same amount of monitoring I've had during the operation, knowing that this patient is high risk. So monitoring assistance, multiple hands, drugs for the transport, and equipment for the transport. I'd have oxygen and have double as much oxygen as I thought I'd need, just in case there's any problems with the transfer, any lift stalling or other problems that might happen on the way. And I'd call ahead and have good communication to make sure that they had a bed ready and we had everything and the process ready. A lot of these professional documents to do with environments, whether it's transfers or inter-hospital transfers or environments like theatre or PACU, I use this format of monitoring, assistant drugs, equipment, and space and personnel and logistics. So I try to use that framework to talk about this. Good. So I think this, then I can keep going on with this viva. So 48 hours later, she's on the ward, systemically well after her unfortunate hemorrhage, postpartum hemorrhage. However, she does have a severe headache. So what is your approach? So again, our approach to anything is to do a thorough assessment, history examination, and relevant investigations of the patient. In this particular circumstance, we're obviously thinking of post-dural puncture headache versus other cause of headache. One of the first things I'm going to state is, this is most likely, depending on depending whether this is positional, frontotemporal headache, it's the right time frame for a post-dural puncture headache. But I'm really concerned about any of the serious differentials, considering that she has had a major crisis and catastrophe occur. So I'm worried about, aside from tension headaches and migraines, I'm worried about intracranial hemorrhage and cortical vein thrombosis. So I'd liaise with the medical team and the neurologist as well to make sure that we're not missing something quite severe. What is typical of a post-dural puncture headache? We've just mentioned a positional fronto-occipital type of headache, and as well the time frame and time course and relieving factors and aggravating factors. What is your treatment for that? So I'd go through simple analgesics, bed rest, and then epidural blood patch as pretty much the end result of failure of these other measures. And then I'd go through discussing how I do an epidural blood pressure. So it's a two-person technique, sterile technique, whereby we insert an epidural, taking the patient's own blood to inject into the space. And essentially we inject about 20 to 30 mils up until the point of feeling pressure. And after this, you may get immediate relief or relief soon after. So thanks for listening. That was the first of these comprehensive vivas on an obstetric patient. Again, I'm trying to pack as much information that you might get asked in any of these kind of obstetric situations, to try to go through as many of the difficult decisions and tricky situations you might want to go through. Thanks a lot.